Welcome to the Deep Dive. Today, we are really getting into it, looking at this pretty intense stack of source material on renal health.
Yeah, it covers a lot of ground.
It really does. Everything from, acute problems right through to end-stage care. So if you've ever wanted that kind of consolidated view on pyelonephritis, kidney stones, AKI, CKD, even transplantation, well, this is it.
Absolutely. And our notes today, they're less about just listing facts and more about analyzing the critical points, the connections.
Yeah, right.
Our mission really is to synthesize all this, take these complicated details, weave them together, show not just what happens when kidneys fail, but why, and crucially, how that decline in one organ, well, it just cascades through the whole body.
From microbe to machine, as you put it.
Exactly. We want to make those connections really clear.
Okay, so the plan is pretty logical. We'll kick off with acute infections, pyelonephritis, then we'll switch to mechanical issues, kidney stones, renal calculi, then tackle the sudden crash of acute kidney injury, AKI. After that, the sort of long, slow burn of chronic kidney disease, CKD, and wrap up with the big interventions. Right. Dialysis and transplant.
Sounds like a plan.
All right, let's jump in at the beginning then. That ascending bacterial invasion.
Okay, pyelonephritis. This is, it's a serious business. We're talking about significant inflammation hitting the renal parenchyma, that's the actual functional tissue of the kidney, and also the collecting system.
And the scary part, as you said, is where it usually comes from.
Right. It's almost always an ascending infection. The bacteria, they start lower down, maybe urethra, maybe bladder, and they literally travel upstream against the flow.
Which is wild when you think about it. And that's what makes it so much more dangerous than just a standard bladder infection, isn't it? That upward path.
Precisely. Because once that infection hits the kidney itself, you're suddenly in the danger zone for urosepsis. And that's not just kidney pain anymore. That's the risk of bacteria spilling right into the bloodstream. Systemic infection, sepsis, organ failure. It can happen fast if you don't stop it.
A real race against time, then.
Definitely. And to stop it, you've got to know the main player. Our sources are clear. Overwhelmingly, it's Escherichia coli. E. coli.
The usual suspect.
Yeah, it's everywhere in the lower GI tract, right? So proximity makes it the most common invader. But, we can't ignore others. There are secondary gram-negatives, things like Proteus, often linked to certain types of stones, actually, and Klebsiella and Pterobacter species, too.
Okay. But for prevention, it sounds like we need to focus on what lets those bacteria make that uphill journey in the first place.
Right.
You need something messing with the normal urine flow, right?
That's exactly it. It all boils down to urinary stasis.
Stasis. Urine just sitting there.
Right. Perfect breeding ground. So factors that cause this, well, there's vesicroidal reflux, VUR. That's a valve issue letting urine flow backwards up the ureters.
All right.
Then you've got mechanical blockages from lower urinary tract dysfunction. So in men, often benign prostatic hyperplasia, BPH, slowing things down, urethral strictures narrowing the pipe, or even, ironically, kidney stones themselves causing a blockage.
And what about in hospital settings? That's a big risk area too, isn't it?
Huge. We absolutely have to talk about catheter-associated UTIs, COUTIs. They basically create a highway for bacteria straight into the bladder, bypassing all the body's normal defenses.
Right. So how does this actually present in a patient? What are they feeling?
It's usually severe, very different from a simple UTI. We're talking profound systemic illness. Patients feel incredibly tired, debilitating fatigue. They get uncontrollable chills, high fevers, vomiting, just this overwhelming sense of being unwell, malaise.
Sounds awful. But how do you clinically pin it down to the kidney?
It really hinges on the localized signs, that severe flank pain side or back pain, sometimes shooting towards the groin. And the big one, costovertebral angle tenderness, CVA tenderness.
That's a tapping test, right?
Exactly. Tapping gently over the kidney area causes significant pain. That points directly to kidney inflammation.
Interesting, though, you mentioned the infection starts low. So could they still have those classic UTI symptoms too, like the burning, urgency?
They absolutely can. Dysuria, urgency, frequency, those might still be present, which can sometimes muddy the waters a bit initially, especially if the really systemic stuff hasn't fully kicked in yet.
Okay, so diagnosis, what are we looking at?
It's pretty comprehensive. First up, urinalysis. You'll see the inflammation, lots of leukocytes, pyuria, actual pus in the urine, and bacteria, bacteriuria.
But you need to know which bacteria and what kills it.
Crucial. That's why a urine culture and sensitivity test is non-negotiable. Mandatory.
And blood tests.
Yep. Complete blood count, looking for that high white blood cell count leukocytosis showing a major infection. And if the patient looks really sick, septic even, then blood cultures are drawn. We need to know if the bacteria have jumped into the bloodstream.
What about imaging, like ultrasounds or CT scans?
Very important, but not just for looking. It's to rule out complications. Is there an obstruction, like a stone blocking things up? Or has the infection walled itself off into an abscess, a pocket of pus inside the kidney?
Because that would change the treatment plan completely.
Immediately, you'd go from just antibiotics to needing some kind of procedure to drain it or relieve the pressure.
So treatment depends heavily on how sick the patient is.
Right. Mild cases might manage as outpatients. But severe infection, signs of instability, can't keep fluids down, that's immediate hospitalization.
And the core treatment.
It's supportive care plus aggressive antibiotics. Supportive means pushing fluids, aiming for maybe 2 to 3 liters a day if possible, using NSAIDs or antipyretics for the fever and pain.
And the antibiotics, you start them right away.
Yes, immediately. You start with empiric broad-spectrum antibiotics.
Empiric meaning best guess based on likely suspects.
Exactly. You hit hard and broad, targeting E. coli and the common players without waiting for the culture results. But, and this is critical, the notes really stress this, you only adjust the antibiotic regimen after you get those culture and sensitivity results back, usually 48, 72 hours.
Why is that adjustment so important?
2 reasons. Effectiveness, making sure you're using the right drug, and stewardship, preventing unnecessary antibiotic resistance by narrowing the spectrum once you know the specific target.
Got it. And from a nursing angle, what are the big priorities?
Timeliness and teaching. Number 1, get those urine and blood cultures before that first antibiotic dose goes in. Super important.
Otherwise, you skew the results.
Right. And then patient education is huge, especially for discharge, stressing how vital it is to finish the entire course of antibiotics, even if they start feeling better after a few days. Stopping early is just asking for trouble recurrence, resistance.
So the goals are pretty clear. Get the infection under control, stabilize the patient, manage pain, and make sure the bacteria are gone.
That's the aim. Restore function, get them afebrile, pain-free, and confirm clearance with follow-up cultures.
Okay, so we've seen how plumbing problems, like stasis, can lead to infections. But what if the plumbing gets blocked by something solid? Let's shift gears completely now from bacteria to, well, rocks, renal calculi.
Kidney stones, yeah.
Or urolithiasis, nephrolithiasis.
Yeah.
Lots of names for the same painful problem. Essentially, we're talking about solid masses forming in the urinary tract.
And what are they made of, usually?
Most commonly, calcium salts. Things like calcium oxalate or calcium phosphate. They tend to crystallize and build up, often around a sort of core scaffolding made of organic stuff, a mucoprotein matrix.
And why do they form? Is it just one thing?
Rarely simple. The sources call it multifactorial, and that's spot on. It's a mix of things. Metabolic issues like maybe you excrete too much calcium or uric acid. Genetics definitely play a role. Environment counts too.
Lifestyle factors seem big here as well. Huge. Things like not drinking enough water, that chronic low-level dehydration, drinking a lot of stuff that concentrates urine, like certain teas or colas, and even just being sedentary, not moving around much.
When you mentioned chemistry inside the kidney matters too.
Absolutely. The urine pH is a big one. Some stones like acidic urine, others prefer alkaline, the overall concentration of minerals, the solute load, and even connecting back existing infections can sometimes promote stone formation, particularly struvite stones.
So who's most likely to get these?
Well, anyone with a personal or family history is at much higher risk. Once you've had one, you're prone to more.
Ugh.
Yeah. Also, dietary imbalances, too much sodium, maybe too much oxalate from certain foods, people with limited mobility.
Right.
And sometimes previous surgeries on the GI or urinary tract can alter absorption or flow and increase risk.
But the thing everyone knows about kidney stones is the pain, right? Renal colic.
Oh, it's unforgettable. It's described as just excruciating, sharp, severe, cramping pain. It's totally disabling for most people.
What causes that specific type of pain?
It's the ureter, that narrow tube from the kidney to the bladder, trying desperately to squeeze and push the stone along through peristalsis. It's fighting against a solid obstruction.
And where you feel it depends on where the stone is stuck.
Exactly. If the stone is still high up, maybe lodged where the kidney meets the UPJ, ureter-pelvic junction, the pain might be more of a dull, constant ache in the flank.
Okay.
But as soon as that stone moves down and gets near the bladder at the ureter-vesical junction, the UVJ, the pain signature changes dramatically.
So?
It starts radiating sharply down to the lower abdomen, the groin, sometimes the genitals. It can easily mimic other acute problems like appendicitis or ovarian issues.
And I imagine nausea and vomiting often go along with that kind of intense pain.
Very common. The intensity of the pain, the visceral reflexes, it often triggers severe nausea and vomiting, which then makes it hard for the patient to stay hydrated or even keep pain meds down.
So how do you diagnose it definitively? Cut through the possibilities.
The gold standard, hands down, is the non-contrast spiral CT scan.
Why non-contrast?
Because you want to avoid giving IV contrast dye if possible, especially if the kidney might already be stressed or injured. The CT is brilliant at spotting the stone, its size, its exact location, and any backup of urine, hydronephrasis, without needing the dye.
Are there other tests involved?
Yeah, supportive tests help build the picture. Urinalysis almost always shows blood hematuria, either visible or microscopic, just from the stone scraping the lining. You might see crystals or an abnormal pH too.
And blood work.
Serum labs like BUN, creatinine, maybe uric acid levels, just to check if the kidney function is taking a hit from the blockage or stress.
And you mentioned prevention earlier. Is there a specific test for that?
Yes. If someone is a recurrent stone former, the 24-hour urine collection is really valuable.
What does that tell you?
It measures exactly how much calcium, oxalates, citrate, uric acid, and other substances the person is excreting over a full day. That data lets doctors tailor very specific planned diet changes, maybe medication, to reduce the risk of future stones based on that individual's metabolic profile.
Okay, let's talk treatment. The notes break it down into 2 phases.
Right. Phase 1 is all about the acute situation, managing the immediate crisis. That means aggressive pain control, often opioids or strong NSAIDs are needed, treating any infection if it's present, and trying to help the stone pass.
How do you help it pass?
If the stone seems small enough, you might use medications called alpha-adrenergic blockers, things like tamsulosin or terazosin. They relax the smooth muscle in the ureter.
Kind of widening the pipe temporarily.
Exactly. Makes it easier for the stone to slip through.
And if that doesn't work, or the stone's too big, that's phase 2.
That's phase 2. Sodium removal and then long-term prevention. If it won't pass or it's causing ongoing problems, you have to go in and get it.
How? What are the options?
Often it's endurologic procedures, using scopes and instruments passed through the urinary tract. The notes mention 4 main types of lithotripsy that's breaking the stone up.
Okay, let's unpack those.
Sure. There's ESWL, extracorporeal shockwave lithotripsy. That's non-invasive. Uses focused sound waves from outside the body to shatter the stone. Good for certain types and locations, minimal recovery.
What else?
Then you get more direct. Laser lithotripsy, usually done during a ureteroscopy where they pass a scope up the ureter. A laser fiber directly targets and vaporizes the stone.
Okay.
Percutaneous ultrasonic lithotripsy involves a small incision in the back, going directly into the kidney. A probe uses ultrasound waves to break up bigger, more complex stones like staghorn calculi. And then there's electrohydraulic lithotripsy, using electrical sparks to break up really tough stones.
And sometimes actual surgery is still needed.
For really large or awkwardly placed stones, yes. Open surgery like a prelolithotomy, removing a stone from the renal pelvis, or ureteral lithotomy from the ureter might be the only option.
And the big risk with those invasive procedures.
Bleeding. Hemorrhage is a significant potential complication mentioned in the notes, so post-op monitoring has to be really careful.
So after all that, the focus shifts back to preventing more stones.
Absolutely. Long-term prevention is key. Hydration is number 1, drinking enough water to keep urine flowing and dilute. But interestingly, not overhydrating to dangerous levels.
Right, and diet.
Reducing triggers like caffeine, colas, lowering sodium intake is often very important. And staying active. Regular physical activity helps.
And for nursing, during that acute phase.
Priorities are managing that severe pain, keeping track of fluids in and out, and this is crucial, straining all the patient's urine.
Why strain it?
Because if they pass the stone, you need to catch it. Sending that stone off for analysis tells you exactly what it's made of: calcium oxalate, uric acid, struvite, whatever. And that information is what allows for truly targeted prevention strategies, whether it's diet or medication.
Okay, we've gone from infections to blockages. Now let's talk about a much more dramatic event, when the kidneys just suddenly stop working properly.
Yep.
Acute kidney injury, AKI.
Right. This is a rapid, abrupt decline in kidney function. The key result is azotemia, that buildup of nitrogenous waste products like BUN and creatinine in the blood, and often sharp rises in potassium too.
And the big difference from chronic kidney disease is?
Potential reversibility. That's the defining feature of AKI, really. If you can figure out why it happened and fix that underlying cause quickly and effectively, the kidneys can often recover function.
So figuring out the why is everything. The notes group the causes into three main types.
Exactly. And understanding these is fundamental to managing AKI. They are prerenal, intrarenal, and postrenal.
Let's start with prerenal. The notes say it's the most common.
It is. Prerenal means the problem isn't actually in the kidney tissue itself. It's happening before the kidney, usually related to blood flow. The kidneys aren't getting enough blood perfusion to filter properly.
Why would that happen?
Often it's the body trying to protect itself, ironically. It senses low blood volume systemically, maybe from severe dehydration, blood loss, shock, or even really bad heart failure.
So the kidney shuts down its own blood supply.
In a way, yes. It clamps down blood flow to the kidney to try and shunt that limited blood volume to more critical organs like the brain and heart. It sacrifices its own filtration rate, the GFR, to maintain central perfusion, restore the blood flow, fix the volume issue, and the kidney usually bounces back.
Okay, that makes sense. What about intrarenal AKI?
Intrarenal means the damage is inside the kidney. Direct injury to the nephrons, the filtering units. This can happen from prolonged lack of blood flow ischemia if that prerenal state goes on too long, or from direct exposure to toxins.
What kind of toxins?
Certain antibiotics like aminoglycosides, heavy metals, sometimes IV contrast dye if not managed carefully, especially in someone already at risk.
The notes also mention things like hemoglobin or myoglobin release.
Right, that's a big one. If someone has a massive crush injury causing rhabdomyolysis or severe hemolysis, these large proteins get released into the blood and they can physically clog up the kidney tubules.
And the most common type of intrarenal damage?
The sources pinpoint acute tubular necrosis, ATN, damage specifically to the tubule cells. The good news, relatively speaking, is that ATN is often reversible with good supportive care, as the tubules can regenerate.
Okay, and the third category? Postrenal AKI.
This one is mechanically simpler to grasp. It's an obstruction after the kidney, blocking the outflow of urine.
Like a plumbing backup.
Exactly. If urine can't get out, pressure backs up all the way to the kidneys, eventually shutting down filtration. Common causes are things we've touched on: BPH, cancers of the prostate or bladder, trauma, or maybe kidney stones blocking both ureters.
So once AKI kicks in, regardless of the cause, it tends to follow a pattern. 3 phases.
Typically, yes. The first and often most critical phase is the oliguric phase.
Oliguric meaning low urine output.
Very low,
Yeah.
defined as less than 400 millimolars per day. This phase can last, maybe a couple of weeks.
And what's happening inside the body then? What do the labs show?
Labs go haywire. BUN and creatinine shoot up because the kidneys aren't clearing waste. Potassium levels climb dangerously because it can't be excreted. Urinalysis shows damage. Casts, red blood cells, white blood cells.
But the immediate danger comes from the complications, right? The body can't get rid of fluid or acid.
Precisely. Fluid retention leads to swelling, edema, and high blood pressure, hypertension. The inability to excrete acid leads to metabolic acidosis.
And the body tries to compensate for that acidosis.
Yes, through breathing. You see cosmal aspirations, these deep, rapid, almost gasping breaths. It's the lungs trying desperately to blow off CO2 to buffer the acid in the blood.
But the most life-threatening complication in this phase.
Without a doubt, hyperkalemia. Higher potassium. Because potassium affects the heart's electrical activity so directly, rapidly rising levels can cause potentially fatal heart rhythm disturbances, arrhythmias. The ECG changes are classic peaked T waves, widened QRS complex. It's an emergency.
And on top of all that, the notes mention infection as a major killer here.
Yes, it's highlighted as the leading cause of death during the oliguric phase. The body is stressed, waste products are building up, fluid is retained. It significantly compromises the immune system, making patients incredibly vulnerable to infections.
Okay, so after that crisis phase, what happens next?
If things start to improve, you enter the diuretic phase. This is where the kidneys start to wake up, but they're not fully healed yet.
So urine output increases.
Dramatically. It can surge to 1 to 3 liters a day, sometimes even more. The tubules can filter water, but still can't concentrate the urine properly.
So the risk flips completely.
Totally. You go from worrying about fluid overload to worrying about massive fluid loss dehydration. And because so much fluid is going out, you can lose a lot of electrolytes too, leading to hyponatremia, low sodium, and hypokalemia, low potassium.
And the final phase.
The recovery phase. This can take a long time, potentially up to 12 months. BUN and creatinine levels gradually return towards normal. But patients need close follow-up because some might have residual kidney damage long-term.
So management boils down to fixing the cause first.
Absolutely. Restore volume if it's prerenal. Stop the toxic drug if it's intrarenal. Remove the blockage if it's postrenal. That's job one.
And fluid management is tricky.
Extremely tricky, especially in that oliguric phase. You have to give enough fluid to maintain perfusion, but not so much that you cause pulmonary edema or worsen hypertension. It's a very fine balancing act.
What about diuretics, like furosemide?
They might be tried, especially loop diuretics like furosemide, to try and kickstart urine output, but if the kidney damage is too severe, they just won't work. They can't force filtration if the filters are broken.
Are certain groups more at risk for API?
Older adults are definitely highlighted. They often have multiple factors converging, taking many medications, polypharmacy, some of which might be nephrotoxic or affect blood pressure. They might have underlying chronic hypotension, and dehydration can sneak up on them easily. You have to be extra careful with drugs like aminoglycosides in this population.
Okay, let's circle back to that deadly complication, hyperkalemia. The notes outline a specific treatment strategy. It sounds like a multi-step emergency plan.
It is. It's designed to protect the heart immediately and then buy time to actually remove the potassium. There are basically 4 key parts.
Step 1.
Immediate cardiac protection. Usually intravenous calcium, either calcium gluconate or calcium carbonate. This doesn't lower the potassium level itself, but it stabilizes the heart muscle cells, making them less likely to go into a fatal rhythm. It buys you precious minutes.
Okay, protects the heart. Step 2.
Shift the potassium out of the blood and into the cells, temporarily lowering the serum level. This is done using IV insulin, which drives potassium into cells along with glucose, often given with glucose, to prevent hypoglycemia, and/or sodium bicarbonate, which helps correct the acidosis and also encourages potassium to move intracellularly.
So, temporary fixes to lower the immediate blood level. Step 3.
Now you need to actually remove the excess potassium from the body. This often involves using sodium polystyrene sulfonate, brand name Kysexelt. It's a resin, usually given orally or rectally, that binds potassium in the gut and exchanges it for sodium so the potassium gets excreted in the stool.
Okay, and the 4th element. Or is that it?
Well, those are the main medical interventions. The 4th consideration, overarching all of this, is dialysis.
When do you need dialysis in AKI?
It becomes necessary if these medical measures fail or if the situation is just too severe. Specific triggers include volume overload that isn't responding to diuretics, life-threatening hyperkalemia or metabolic acidosis that can't be controlled medically, a BUN level climbing really high, like over 120 milli-GDL, significant changes in mental status indicating uremic encephalopathy, or signs of pericarditis, inflammation around the heart.
All right, so AKI is the sudden, maybe fixable problem. Now we turn to the other side of the coin. Chronic kidney disease, CKD. This is the slow, progressive, irreversible loss of kidney function.
That's the key word. Irreversible. We define it usually as a glomerular filtration rate, GFR, below 60 milliliter per minute per 1.73 meters squared. That persists for more than 3 months. Or other clear signs of kidney damage, like persistent protein in the urine.
And what's driving this long-term failure? What are the main causes?
The big 2, responsible for the vast majority of cases, are diabetes mellitus and hypertension. High blood sugar and high blood pressure relentlessly damage the delicate filtering structures in the kidneys over years.
Are there other causes too?
Yes. Secondary causes include things like chronic inflammation of the glomeruli, glomerulonephritis, inherited conditions like polycystic kidney disease, or long-term urinary tract obstructions.
And one of the really tricky things about CKD is that you might not know you have it for a long time.
Exactly. It's incredibly insidious. The kidneys have a lot of reserve capacity, so nephrons can be gradually destroyed over years without the person feeling any symptoms at all. Often, it's not until the GFR drops really low, sometimes below 20% of normal, that the systemic consequences really start to manifest.
And when they do manifest, it's not just about the kidneys anymore, is it?
Not at all. This is where you have to stop thinking of it as just a kidney problem. CKD is systemic failure. When your main filtering and regulating organs start to shut down, virtually every single system in the body feels the impact.
Okay, let's try and walk through some of those systemic effects, starting with the urinary system itself.
Well, early on, as the kidneys lose their ability to concentrate urine, patients might actually experience polyuria, producing large amounts of dilute urine. But as the disease progresses and more nephrons are lost, that shifts inevitably towards oliguria, low output, and eventually anuria, no urine output in end-stage disease.
What about metabolic changes?
Azotemia, that buildup of waste products like BUN and creatinine, becomes progressively worse. The kidney's hormonal functions are also impaired, which can mess with glucose tolerance, leading to altered carbohydrate metabolism. And patients often develop high triglycerides, adding to their cardiovascular risk.
Electrolytes must be a huge issue, too.
Huge and constant. Hyperkalemia, high potassium, is a major danger because the kidneys can't excrete it properly. Phosphate levels also rise dramatically because filtration fails, and the body drifts into a state of chronic metabolic acidosis because it can't get rid of acids or regenerate bicarbonate effectively.
And hematologically, effects on the blood.
Very significant. The most prominent is severe anemia. This happens because the failing kidneys stop producing enough erythropoietin or EPO.
That's the hormone that tells the bone marrow to make red blood cells.
Exactly. No EPO signal, no red blood cell production. Patients also tend to have problems with platelet function, leading to increased bleeding tendencies, and their immune system gets suppressed, making them much more vulnerable to infections.
Cardiovascular seems like another major area of impact.
Catastrophic, really. The combination of fluid retention and the overactivation of the renin-angiotensin system leads to severe, often hard-to-control hypertension.
Which then damages the heart and vessels further.
Right. The high pressure and fluid overload contribute directly to heart failure. Plus, the disordered calcium and phosphate metabolism leads to calcification within blood vessels, worsening peripheral vascular disease, and increasing the risk of heart attacks and strokes.
What about breathing?
Well, fluid overload can cause shortness of breath, dyspnea, and again, you might see those cuspal respirations as the body tries to compensate for the chronic metabolic acidosis.
And the GI system. How does uremia affect digestion?
It's pretty rough. The buildup of toxins causes inflammation throughout the GI tract. You see stomatitis, mouth sores, constant nausea, vomiting, delayed stomach emptying called gastroparesis, and that classic sign of advanced uremia, uremic fetor, a kind of metallic or ammonia-like smell on the breath.
Neurologically, how does it affect the brain and nerves?
The retained toxins are neurotoxic. Patients commonly experience crippling fatigue, difficulty concentrating, confusion, memory problems. Peripheral neuropathy is very common too, tingling, numbness, restless leg syndrome. And in severe late stages, it can progress to uremic encephalopathy, leading to seizures, stupor, and coma.
Wow. Okay, and the notes mention a specific link between CKD and bone health. CKD-MBD.
Yes, chronic kidney disease mineral and bone disorder. This is really complex, but incredibly important. It starts with the kidneys failing to excrete phosphate.
So phosphate levels rise in the blood.
Right. That high phosphate then binds to calcium, effectively lowering the amount of free active calcium in the blood.
And the body senses that low calcium.
And the parathyroid glands go into overdrive. They start pumping out huge amounts of parathyroid hormone, PTH, trying to get calcium levels back up.
How does PTH raise calcium?
Primarily by pulling it along with phosphate directly out of the bone. So you get this constant leaching of minerals from the skeleton.
Which weakens the bones dramatically.
Exactly. It leads to conditions like osteomalacia, softening of the bones, and osteoitis fibrosa, where bone is replaced by fibrous tissue. The bones become brittle and prone to fracture. It's a vicious cycle driven by the kidney failure.
Even the skin is affected.
Yes, severe itching, pruritus, is a very common and distressing symptom. The exact cause isn't perfectly understood, but it might relate to toxin buildup or calcium phosphate deposits in the skin. And in very advanced uremia, you might even see uremic frost, visible urea crystals forming on the skin as sweat evaporates.
Goodness. So diagnosis involves looking for all these signs.
Diagnosis confirms the kidney damage and stages it. Urinalysis looking for protein, especially the albumin to creatinine ratio. Serum creatinine and calculating the GFR are key for staging. Imaging like ultrasound can show kidney size and rule out structural issues. Sometimes a biopsy is needed.
And management. What are the main goals?
The absolute top priority is slowing down the progression of the disease. And the single best way to do that is strict blood pressure control.
What medications are used?
ACE inhibitors, or ARBs, are usually first line. They have a specific protective effect on the kidneys beyond just lowering blood pressure by reducing pressure inside the glomeruli. Diuretics are often added for fluid management.
What else is crucial for slowing things down?
Managing dyslipidemia, high cholesterol, and triglycerides. Statins like atorvastatin are used for LDL cholesterol, and fibrates like gemfibrozil might be used for very high triglycerides. It's all about reducing that massive cardiovascular risk.
Okay, now let's talk about treating those specific complications we walk through, especially the bone disease, CKD-MBD.
Right. Since high phosphate drives it, phosphate binders are essential. These are medications taken with meals
Why with meals?
because they work in the gut. They grab onto the phosphate from the food you just ate and prevent it from being absorbed into the bloodstream. If you take them on an empty stomach, they miss the phosphate load entirely.
What are some examples?
Calcium acetate or calcium carbonate are common, but they add to the calcium load. Sevelamer is a non-calcium-based option.
And what about the high PTH levels?
We need to address that too. Since the kidneys normally activate vitamin D, patients often need supplementation with an activated form like calcitriol. And if PTH levels remain sky high despite phosphate control and vitamin D, medications called calcimimetics, like simicalcet, can be used.
How do they work?
They basically trick the parathyroid gland into thinking calcium levels are higher than they are, which signals it to produce less PTH.
Okay, what about managing the anemia?
That requires replacing the missing EPO signal. We use erythropoiesis-stimulating agents, ESAs, like epoetin alpha or darbepoetin. These are injections that stimulate the bone marrow to make red blood cells.
Does it work quickly?
No, patients need to understand it takes maybe 2 to 3 weeks to see a real increase in hemoglobin and hematocrit. And critically, ESAs only work if the body has the building blocks for red cells. So patients almost always need supplemental iron and sometimes folic acid too.
Finally, nutritional therapy. It sounds like the diet becomes incredibly restrictive.
It's very challenging and highly individualized. Protein intake is a big one. Before dialysis, it's often restricted. Interestingly, once on hemodialysis, protein needs are about normal, but on peritoneal dialysis, they actually need higher protein because they lose some in the dialysate fluid.
What about sodium in fluids?
Those are tailored very carefully based on how much urine the patient is still making, their blood pressure, and signs of fluid retention.
But potassium and phosphate seem universally restricted.
Absolutely critical restrictions. Potassium is usually limited to maybe 2 to 3 grams per day, and patients have to be warned very strongly about salt substitutes. Many are made with potassium chloride and can be really dangerous.
And phosphate.
Also tightly restricted, often to around 1 gram per day. This means cutting back significantly on high phosphate foods like dairy, nuts, beans, processed meats, even while taking phosphate binders. It's a constant balancing act.
So when CKD reaches its final stage, end-stage kidney disease, or ESKD, conservative measures aren't enough. The kidneys have failed, and something needs to take over their job. That's where renal replacement therapy comes in. Dialysis.
Right. Dialysis becomes necessary to sustain life. It corrects those dangerous fluid and electrolyte imbalances and removes the accumulated waste products that the kidneys can no longer handle.
When do doctors usually decide it's time to start?
The typical threshold is when the GFR drops below 15 mmmin 1.73 meter millis, or sometimes sooner if the patient develops severe uremic symptoms that can't be controlled otherwise, like the encephalopathy, severe hyperkalemia, or fluid overload we talked about.
And there are two main types of dialysis, offering very different approaches.
Yes, peritoneal dialysis, PD, and hemodialysis, HD.
Let's start with PD. How does that work?
PD uses the patient's own peritoneal membrane, the natural lining of their abdominal cavity, as the filter.
How?
A soft catheter is surgically placed into the abdomen. Then a special sterile dialysis solution, dialysate, is infused into the peritoneal cavity. That's the inflow phase. Okay. Then the fluid sits there for a prescribed period called the dwell time. During this time, waste products and excess fluid diffuse from the tiny blood vessels in the peritoneum into the dialysate, following concentration gradients.
And
Then comes the drain phase, where the used dialysate, now full of waste, is drained back out of the abdomen. Sometimes the patient needs to shift position a bit to help it drain completely. That whole cycle, inflow, dwell, drain, is called an exchange.
what are the pros and cons of PD?
The big advantage is independence and flexibility. It's usually done at home, often automated overnight while the patient sleeps, APD, or done manually several times during the day, CAPD. It's gentler, more continuous.
But the risks.
The main risks are infection either at the catheter exit site or, more seriously, peritonitis, an infection inside the abdominal cavity, which can be very dangerous. There's also a risk of hernias from the constant fluid pressure, potential pulmonary issues, and, as we mentioned, protein loss through the peritoneum.
Right, requiring that higher protein diet.
Ex-
Okay, now hemodialysis, HD. How's that different?
HD is more like an external artificial kidney. The patient's blood is circulated outside the body through a machine with a special filter called a dialyzer.
How does blood get to and from the machine?
That requires reliable, high-flow vascular access. The gold standard, the preferred method, is an arteriovenous fistula, or AV fistula.
What's that?
It's created surgically by directly connecting an artery and a vein, usually in the forearm. The high pressure from the artery makes the vein enlarge and toughen over weeks or months, creating a vessel that can handle the large needles and high blood flow rates needed for dialysis.
Why is a fistula preferred over other options like grafts or catheters?
Lower infection rates, much less likely to clot, and they tend to last much longer. Grafts are synthetic tubes connecting an artery and vein, and catheters are central lines. Both have higher complication rates.
And checking the fistula is working is crucial before every treatment.
Absolutely critical nursing task. Before hooking the patient up, you must assess the fistula. You feel for a palpable thrill. It feels like a buzzing or vibration under the skin, indicating good flow. And you listen with a stethoscope for an audible bruit, a rushing or whooshing sound.
No thrill or bruit means.
Big trouble. It likely means the fistula has clotted or isn't working properly, and dialysis can't proceed until it's checked out.
What happens during the actual HD treatment?
It's usually done 3 times a week, for maybe 3-5 hours each time, often in a dialysis center. During the treatment, monitoring is constant, checking vital signs frequently, usually every 30 to 60 minutes, watching the patient closely.
And managing fluid removal.
Yes, the machine actively pulls off excess fluid that's called ultrafiltration. The rate of removal has to be carefully calculated and adjusted based on how much fluid weight the patient gained between treatments to avoid pulling fluid off too quickly, which can cause problems.
Like what kind of problems? What are the common complications of HD?
Hypotension, a sudden drop in blood pressure, is probably the most common, especially if fluid is removed too fast or if they took blood pressure meds right before coming in. Muscle cramps can be frequent too, often related to fluid shifts. There's also a risk of blood loss, and historically, hepatitis transmission was a concern, though much less so now with better screening.
The notes also flag something called disequilibrium syndrome.
Yes, that's a specific, potentially serious neurological complication. It happens when dialysis is very efficient, especially when starting treatment or if someone is very uremic.
How does efficiency cause a problem?
The dialyzer removes waste products like urea from the blood very quickly, but urea takes longer to shift out of the brain tissue across the blood-brain barrier. So for a period, the blood becomes much cleaner or less concentrated than the brain tissue.
Creating an osmotic imbalance.
Exactly. Water follows solutes, so water moves from the cleaner blood into the more concentrated brain tissue, causing cerebral edema swelling of the brain.
Yikes. What are the symptoms?
Headache, nausea, vomiting, restlessness, confusion. In severe cases, it can even lead to seizures. It highlights how dialysis is powerful, but needs careful management to avoid these kinds of rapid shifts.
Okay, so dialysis keeps people alive, but it's demanding. What about transplantation?
Kidney transplantation is really considered the treatment of choice for most people with ESKD. It offers the best chance for long-term survival and significantly better quality of life compared to dialysis.
How so?
It essentially reverses most of the uremic symptoms. It frees the patient from the time commitment and restrictions of dialysis. Functionally, it's the closest thing to having working kidneys again.
But getting a transplant isn't easy. There's a waiting list.
Yes, a long one. In the U.S., the average wait time for a deceased donor kidney is around 3 to 5 years, sometimes longer depending on blood type and other factors.
But the outcomes are good if you get one.
Very good. 1-year survival rates for the transplanted kidney are typically around 90% for deceased donor kidneys, and even higher, maybe 95%, for kidneys from living donors.
Who can't get a transplant? Are there contraindications?
Yes, there are definite contraindications. Things like active infections, untreated cancers, severe heart or lung disease that would make the major surgery too risky. Morbid obesity can be a factor, as can ongoing substance abuse. The patient needs to be healthy enough for the surgery and able to manage the complex post-transplant care.
And that post-transplant care involves lifelong medication.
Absolutely critical. Lifelong immunosuppression is required. The body's immune system will naturally see the new kidney as foreign tissue and try to attack and destroy it. That's rejection. Immunosuppressant drugs dampen that immune response to protect the transplanted organ.
What are the main types of drugs used?
The cornerstone drugs are often calcineurin inhibitors like tacrolimus or cyclosporine. They're very effective at preventing rejection.
But there's a catch.
Yes, the big catch is that they themselves can be nephrotoxic, damaging to the kidneys, including the new transplant. So dosages have to be managed incredibly carefully, with frequent blood tests to monitor drug levels, finding that balance between preventing rejection and avoiding toxicity.
Are there specific side effects for these?
Tacrolimus, for example, commonly causes tremors, headaches, sometimes insomnia. Cyclosporine can cause high blood pressure and gum swelling.
What other drugs are typically used?
Corticosteroids, like prednisone, are also mainstays, especially early on. They are powerful anti-inflammatories, but come with a host of well-known side effects: weight gain, high blood sugar, mood changes, increased infection risk, and long-term osteoporosis.
You can't just stop steroids suddenly.
Absolutely not. They suppress the body's own adrenal function, so they must always be tapered off slowly under medical supervision to prevent an adrenal crisis. And taking them in the morning, often with food, helps mimic the body's natural rhythm and reduce stomach irritation.
So life after transplant is still complex.
It's a different kind of complex. The focus shifts entirely to meticulous medication adherence, recognizing early signs of potential rejection or infection, since the immune system is suppressed, and lifelong regular follow-up with the transplant team for monitoring. Compliance is everything. Hashtag outro, outro.
Wow. Okay, that was definitely a deep dive. We went all the way from, a simple UTI potentially escalating to pyelonephritis and sepsis,
Mm-hmm.
through the sheer mechanics and agony of kidney stones, the sudden functional shutdown of AKI with its electrolyte emergencies.
Right, that hyperkalemia danger.
Exactly. And then into the really complex, slow systemic breakdown of CKD, affecting literally everything from bones to blood to brain.
And finishing with the technologies that replace kidney function dialysis with all its demands, and transplant with its own set of lifelong commitments like immunosuppression.
I think the biggest takeaway for me, synthesizing all these notes, is just how interconnected everything is. You can't think about the kidney in isolation. Its failure truly ripples through every single body system.
That's the crucial insight. CKD isn't just filtration failure, it's endocrine failure, no EPO, no active vitamin D. It's hemodynamic failure, hypertension, heart failure. It's skeletal failure, that whole CKD-MBD complex. It really drives home the kidney's central regulatory role.
And understanding these details, like why phosphate binders need to be taken with meals, or how to check for a brute and thrill in a fistula,
Yeah.
it gives you that informed perspective we were aiming for.
It absolutely does. It bridges the gap between the diagnosis and the day-to-day reality of managing these conditions.
So here's maybe a final thought to leave our listeners with, drawing from everything we covered. Considering the sheer number of chronic, serious complications that come with end-stage kidney disease, the anemia needing EPO, the bone disease needing binders and vitamin D, the hypertension needing multiple drugs, the dialysis itself, or the lifelong immunosuppression after transplant.
It's a lot to manage.
It's immense. So how incredibly challenging must it be, both for the clinicians and especially for the patients, to juggle and prioritize all these different simultaneous crises every single day? The kidney failure might be the root cause, but living with it means constantly managing maybe a dozen other chronic conditions, all demanding perfect adherence just to stay stable. It really puts the patient burden into perspective.